I'm going to be talking to you about the initial surgical steps once you've got your graft prepared. So all of our patients get a sub-T9 block. We mark the cornea, make our incisions, insert an AC maintainer, and then do a desmetorexis prior to injecting our tissue. So we don't use any preoperative drops for our patients, and no constricting drops. If it's a combined case, we don't use any dilating drops for the phaco, apart from a drop of antibiotic. And all of our patients get a sub-T9 block, which you can see me doing here with a medial incision, inserting a blunt cannula behind the globe, and we usually inject 3 mils of a mix of Narcan with lidocaine. This is often done by a second surgeon while the graft is being prepared, even without the microscope. And we use Myocol intraoperatively, we don't use pilocarpine pre-op. So when we mark the cornea, we use calipers rather than using a large amount of ink on the tree fine. So we find a small amount of ink doesn't get in the way, whereas a larger amount of ink can get in the way of visualizing the edge of your tissue or even the mark at times. And we position our marks at a place where we're going to put our paracentesis so that we don't have to go looking for them. Our default size of desmetorexis is about 8.25 millimeters, but obviously that depends on the size of your eye, which you can measure with your white to white beforehand prior to preparing the tissue. We always sit at the head for the right eye and temporally for the left eye. We just find that's more ergonomic for injecting the tissue. Either way, our main incision is always supratemporal, and we make 2 paracenteses for manipulation of fluid and air, and 1 for the AC maintainer. So you can see that the paracenteses are at 10 and 2 o'clock, and the AC maintainer is inferotemporal in both eyes. So I'll just play the video again. If you pay attention to the MBR blade which we use, for this paracenteses at 10 and 2, we don't enter the eye completely, and that creates a better seal when we're injecting air into the eye. Whereas for the AC maintainer, we do enter the eye completely to fit the cannula that we're going to use. So we've moved to a 2.2 millimeter incision with our main wound, and we always do a vertical cut down so that we ensure that the wound is beveled and airtight, because we tend not to suture our wounds at the end of the case. We try to make them as nimble as possible, and as mentioned, supratemporal, even though you're sitting temporally in the left eye. And we find that doing that will decrease peri-wound edema and get the graft to overlap there, as well as our air bubble to overlap in that area. So we always like to use an AC maintainer, and we find that it helps to maintain the AC for injecting the graft. It's easy to strip desmase underneath it. It keeps the lens and any vitreous, which hopefully isn't coming forward, back as well. And we control the AC maintainer using a clamp. We used to use the foot pedal, but we found that if you inadvertently push down on the foot pedal, you can easily eject your graft. So it's easier just to use a mosquito on the tubing itself to make sure that it's occluded. So with our desmetorexis, entering through the paracentesis maintains a stable anterior chamber. Don't use your main wound. We use a reverse Sinski and then a 90-degree scraper. We like to start the edge of the desmetorexis with the Sinski and then actually push in centrally from the edge of the desmetorexis using the Sinski hook and then the scraper. Once you've got most of the desmase separated, you can use a Utrada forceps or a micro forceps to pull out your desmase. In the video you can see I'm injecting Vision Blue after we've done our desmetorexis, and that highlights tags in the desmase membrane which have been left behind, so you can go back and retrieve those. So now we're ready to inject our graft.